Dear advances in Neuro Oncology, write your story in sky. This session is supported by Accuray. Now, may I have the honor of inviting the respected chairpersons, Dr. Rakesh Jalali, Medical Director and Professor of Radiation Oncology at Apollo Proton Cancer Center, Chennai. He is also the Senior Advisory Council of ISNO. May I also invite Dr. I.C. Prem Sagar, Chief of Neuro and Spine Oncology Services, Rajiv Gandhi Cancer Institute, Delhi. So, Sir, Dr. Richard Zimmerman is already online. So can we have this talk first, and could you please invite him?
Hello. Dr. Richard S. Zimmerman is Professor of Neurosurgery and Chair at the Mayo Clinic, USA. He is Chairman of the Education Committee also, and he's Medical Director of Education and Chair of Quality Outcome Subcommittees. He received Mayo's Lifetime Achievement Award also. And he's going to speak on the cranial robotic surgery upgrade with technology. Now, robots in neurosurgery has, I used it in 2000 when I was working in Detroit. And now also the Medtronic has got a robot for the placement of the, for the biopsies, and as well for the, when we use the functional, yes. For the functional neurosurgery also, for the placement, this robot is being used. So let us find out what Dr. Zimmerman is telling about the new robots for neurosurgery. Thank you.
Well, thank you so very much for having me speak to this group. It is my pleasure. I hope I can share my screen with you. Let's see. And let's see. Oh. Where is my screen?
Yes, sir, your screen is visible. We can currently see your desktop. Yes, sir, we can see your slides now.
Okay, well, very, very good. So good afternoon, everyone. Thank you very much for inviting me. I do have a few disclosures. I have worked in the past as a consultant for Medtronic and have worked in development of their robot, or their auto guide, as it's more properly known. I have several of the consulting jobs, although none related to what I was discussing today, and I serve on some medical advisory boards. So robotic systems can be quite complex, and sometimes the discussion of robotics in surgery gets a bit amplified. Obviously, we'd like to have something that is autonomous, and we program it to do some surgical procedure, and it runs and does everything as well as my vacuum here does. The vacuum is quite amazing. You program it once, it actually then maps the room, it cleans, it empties itself, it recharges itself. We're not there surgically. Most of the robotic systems are dependent systems. They work with the surgeon, do not replace the surgeon, but they will augment the surgeon and what we can do surgically in the operating room. So as I mentioned, the surgical robotic systems can augment human ability. From an accuracy standpoint, it's been proven that we can get sub-millimeter accuracy in the ideal environment. Now, I put an asterisk next to that because in the brain, when we place electrodes and do biopsies and do laser ablation, there are things that interfere with our best plans. There's arachnoid brain tissue, blood vessels, the ventricles. So the accuracy ideally is one thing. In the reality of doing surgery, sometimes it's not as precise. The precision, though, in terms of repeatability, getting to the same place, location, identification of the identical place numerous times is very high with robotic systems. And of course, it's quite reliable. They don't get tired or fatigued. And then, of course, the fine motor control of certain robots that I'll discuss really has to do with the stability and motor control, fine motor movements, the precision with which the surgeon's hands can be transmitted to the patient's brain, if you will, is quite amplified and augmented. Now, there are clearly some limits with robotic systems. The unexpected, if you don't program something into a robot, it doesn't know what to do when it encounters a new situation. And so if you're resecting a tumor with a robot, or you think about a robot resecting something or helping you resect, it doesn't know if it's a vessel that feeds the tumor or a vessel that's in passage that feeds normal brain just on the other side of the tumor. And clearly the biggest risk that we face is emergencies. Bleeding and swelling in the brain is unfortunately one of the biggest problems we have in neurosurgery. And when those things occur, you need to take unexpected tasks at hand that you can't program for. So at this point, some things are the limitations of robotics, but I'll discuss a little bit more about that in a second. So before I go forward about robotics and give a few clinical examples, I do have to pause and give recognition to the significant impact that neuroimaging has on any neurorobotic surgery. The ability of digital imaging, three-dimensional imaging, MRI, CT scan, and the quality of those images, superimposition of functional MRI, DTI, and tractography, those things have made an immense difference to allow us to do a robotic type of surgery. Whereas the robots that are used by general surgeons are accompanied by cameras that let you see into the abdomen, as an example. We don't really see into the brain frequently. In robotic surgery, we're typically looking at imaging and neuro navigation. So that's the second component of something that neurorobotics is dependent on. The anatomic spatial co-registration of the patient's brain or patient's anatomy in space superimposed on our imaging is key to successful robotics for the most part. There are some direct robotic surgeries, and I'll address that. But for the most part, the commercially available materials and surgeries that are done really depend on neuronavigation. And what we're doing is dependent upon a linkage between what's happening in the patient and what we're watching on a neuro image. Now, in addition to the neuroimaging, I must give a nod to my colleagues in neuro oncology and radiation oncology who have actually been doing non-invasive robotic neurosurgery for some time. So as much as the surgeons think that we do open surgery or stereotactic surgery with some eloquence, things like the LINAC, linear accelerator, which has, if you will, a robotic arm that allows the radiation source to travel in a programmed arc, a table that functions in a programmed way, and certainly something like the CyberKnife, which is a robotic arm that at the end of the arm has a radiation source. Those are robotic surgeries that are performed non-invasively. So those are some of the forerunners of what we do in open surgery or invasive surgery, so to speak. But again, a nod to those specialists and practitioners and all the support that they received, both mechanically and the physicist side, because they also have been able to perform robotic surgery. Now, one last comment I will talk about is virtual reality. Again, we talk about doing programming, and whether it be the programming of a biopsy pathway, implantation of electrodes, placement of a laser ablation catheter, or even open surgery, getting the knowledge of your anatomy is key to making a successful program. And a more intimate understanding of the anatomical relationships that you're going to face during surgery become key to successful programming, if you will. And this includes things like trajectory, entry points, target points, and how you're going to approach lesions intracranially. Now, robotic neuronavigation, for the most part, in clearly a majority of cases, is really based on two dimensions. The dimension of the trajectory, you define an entry point on imaging, you define a target point on imaging, and the robot will place an alignment guide or guide tube along that trajectory. And the second thing it gives you is the distance. So at what point do you insert a probe or a biopsy needle or an electrode or a laser? The trajectory and distance are the two functions that most robotics are useful for. Now, in the picture here, you see a ROSA robot. It stands for Robotic Surgical Assistant. And this robotic arm, similar to the robotic arm of, let's say, a CyberKnife, really moves with a great degree of freedom and simply places a guide tube on the surface of the brain or near the surface of the brain that allows you to both drill through the bone at the correct angle and then gives you the appropriate distance to target to allow you to insert whatever therapeutic tool you're going to use. The forerunner or the primary use of these are the functions of stereotactic biopsy, and as well for treatment, more recently, laser ablation catheters depend upon robotic navigation to get the location accurately. Now, functional neurosurgery was mentioned during the introduction, and I really appreciate that. Stereo EEG, multiple electrode placements for EEG monitoring, intracranial EEG monitoring. And then, of course, deep brain stimulation is a new frontier that we also face. And in that location or in that application, the accuracy, sub-millimeter accuracy, can have some significant import and impact. As most surgeons will recognize, sub-millimeter accuracy within brain biopsies, probably not that important, but in functional neurosurgery, it may be, depending upon what we are trying to stimulate. And the accuracy of robotics versus conventional frame-based stereotaxis, and for those of you who aren't familiar with frame-based stereotaxis, in both robotic and frame-based stereotaxis, the patient's head needs to be fixed in a non-movable or registrationable position, typically a mechanical fixation device. And then the human, in arc-based or frame-based stereotaxis, slides a guide tube along two arcs that align with programmed trajectory. The human is what finally selects the final position of the guide tube on the arcs, whereas in robotics, obviously, the robot and programming of the robot is what determines it. Now, in this one study, we talk about the comparison of robotics and frame-based, and the accuracy is quite close, although a quarter of a millimeter is pretty comparable. Now, robotic neurosurgery, in terms of augmenting human ability in open procedures, gives and delivers precision, reliability, and stability in motor control. And that's basically the elimination of tremor and the reduction of fatigue. In Calgary, Canada, the neuro arm has been developed. This is not a picture of a neuro arm, it's a picture of a typical robotic surgical procedure, but the neuro arm is the same concept developed for brain work. And you have a surgeon sitting at a working console who has handles or manipulators that do move robotic arms in very fine increments, but the patient still has an open craniotomy, just like normal open surgery, and they are used in very limited function. This type of robotic function, the neuro arm, has very limited applications thus far in neurosurgery, but it is quite advanced. Now, I do want to close by giving you some quick examples of what's happening with current developments in, let's say, smaller degrees of robots. The ROSA robot is about a 4-foot high device. It's quite large and bulky and extremely heavy. Others have developed more compact robotic or guidance systems, if you will. This is a manual system. I will try and do my best to point. You can see there are two controls here, and then attachment to an articulating arm. Those are all manually adjusted by the surgeon as best they can align a trajectory to a target in the brain with this guide tube. And then the conventional drilling is done after alignment is made. But the degree of alignment that's possible through this device with these adjustments is really difficult to say is actually precise. It works well, but we have advanced to more advanced techniques. And this is a Medtronic robot, or what they call the auto guide, which is really quite appropriate because it is really not autonomous at all. But you can see in the video, in this area on the top, the icon that flicks back and forth. For this robot or this auto guide, you need to get it close enough with the human hand, then you lock it in place on a frame or articulating arm. And then when you're close enough, the robot does the final adjustments. Here's a close-up, and you can watch the icons change. You can see the icon here says you're not close enough. And then you'll see as it's moved fairly grossly by the human hand, you hit the icon change to indicate that you are close enough. And there's a fair amount of leeway in how much that can be to be quote unquote close enough. And then what happens is you'll notice here, the robot moves in small increments to finally and accurately adjust the trajectory. And you can see in the changing icon, it goes from that picture to one of, when it gets on target, you can see that the icon changes. Just a close-up, The indications and marking on the patient's scalp here are a rough indication of where we'd like to enter, but the robot finalizes it. And what we do is we place into this trajectory hole our drilling guide, which has a programmable depth stop, so we know exactly how far to drill just through the bone to the dura, and the dura can be coagulated, and then biopsy, laser ablation, or whatever other procedure needs to be done can be performed. The error for this is very small, and you can see here that this is a picture of the image guidance screen, and that with neuronavigation, as the robot aligns itself, it adjusts small increments to get a high degree of accuracy, and that gives us good confidence. And this was targeting based on an MRI in this patient for a tumor, but the CT is up because the CT measurement gives us the depth of bone to drill with, and that augments and completes the robotic programming. Finally, as I said before, these are not autonomous devices. In all the robotic cases, you need to have a dead man switch, or the surgeon still needs to be in control. You can see in this, I'm holding the device and allowing it to move all the time, being able to stop it at any point in time for safety. You can see up here, the icon has changed on the robot to the bullseye type icon, indicating the final position has been reached. There is a joystick for, if you will, manual manipulation and adjustment if necessary, if something is encountered. But for the most part, that's really not used, as the robot programming does everything that's necessary. So obviously, if we have a tumor deep in the brain, posterior fossa, brainstem, or biopsies anywhere in the brain that really isn't amenable to open procedures, we like to develop plans that include a plan that's ideal and a plan that's real. What happens with the robot is to try and really emulate the plan. And getting to targets that are not necessarily easily accessible, or patients prefer not to have open surgery, is one of the ideal candidates for robotic surgery. So with that, I just want to say thank you once again for inviting me to speak. It has been my pleasure.
Thank you very much, Dr. Zimmerman. You have very nicely elucidated that the robot, which is now available for the neurosurgeons, is really to reach at the target very precisely. So the posterior fossa which you have shown was very good. We also use this auto guide and do a lot of biopsies. It is very precise, and the best part is that you have to make a small nick in the skin and make a small bone hole with a drill, and in the skin you require just one suture. That's all. Now this the talk is open for the question. If in the audience you have any question. Patak, please.
Thanks very much for the talk. The present day situation is only limited to reaching target, doing biopsy, and doing minimally sort of invasive procedures. What do you see the role of the robot in coming years or decades to do the proper surgical tasks, which still is not done with the robot? And how do you view that? We are doing a lot of robotics with spine now, putting screws and things like that, which is very precise. That's okay. But still in the brain, we are lagging behind. And because there are shifts and other things, which factors, and swelling and hematomas and bleeding and all those things.
Thank you very much. I agree completely with what you said. In the spine, though, at the current state, it's pretty much just like in the brain for stereotactic. The spinal robots provide alignment. So you can do drilling in pedicles, and then you can do a hardware placement. And potentially some navigation, but mostly the spine work is, again, a trajectory device, highly accurate. Now, the question about open surgery, I mentioned the group in Calgary that have done the most work on open surgery with robotics. It's really not programming. It's still the surgeon using, if you will, a micromanipulator that reduces tremor. If the surgeon's hand can control 2 millimeters, the robot can get down to 0.2 millimeters in terms of controlling a bipolar. I think it has still remains to be seen where the role of that's going to be in open neurosurgery. Programming is typically what the robots, in a true robot sense, you'd like to do. Just like my Roomba, cleaning the carpets. You'd like to have it programmed and it does the operation. We're nowhere near that. It still depends heavily on the human. How much we augment the human ability is the real question. The navigation, the neuronavigation augments our ability to quote unquote see in the brain when we can't see in the brain. Laparoscopic surgery, they go in the brain, they can see everything in the belly. You know, we can't do that surgically. You can't, if you will, go in and just take a look around the brain to see what's there. You need to know where you have to go and get the tumor out. You mentioned appropriately, again, swelling, bleeding, things that you don't program for. And how do you manage that? And when does the surgeon have to rescue the robot? If it was just a robotic only type of procedure, still will be a need that you can't get rid of the surgeon. So thank you very much for that question, though.
Thank you, Dr. Zimmerman. It was a great pleasure to having, and maybe next time you can visit us in person. And thanks
I would
again
love that.
for all your contribution. So it's my
Thank you so
pleasure
much.
Okay, thanks very much again. It's my pleasure to introduce to you the next speaker, Dr. Vaishali Suri, who's a professor of neuropathology at the All India Institute of Medical Sciences and very accomplished neuropathologist. And she's going to talk to us about methylation profiling, which we have been hearing for the last 2 days. They say, I'm curious. So we are curiously waiting for your presentation. Dr. Suri, please.
Thank you, sir, for the kind words. And first of all, I would like to thank Dr. Indu and Dr. Aditya for giving me this opportunity. I'll be discussing methylation profiling of CNS tumors, the basic technique and its pros and cons only as a diagnostic tool in the clinic. So I am not talking about methylation profiling as a research tool. So we all know that in the 2021 edition, that is the 5th edition of CNS WHO classification, many entities have been introduced based on the results of large-scale NGS datasets, epigenetic and transcriptome profiling. And we all know that DNA methylation is the most recognized epigenetic mark in the human genome and is an excellent research platform. But it has also been proclaimed to be enhancing diagnostic accuracy and tumor subclassification, and has been introduced either as a desirable criteria or as an essential criteria for majority of the CNS tumors in the 2021 classification. So I would like to discuss the reliability of this platform in terms of its precision, accuracy, technical problems and TAT, and also the affordability in terms of infrastructure and manpower. Methylation array is a very laborious array which needs at least 8 days of experiments right from DNA isolation till your data is ready to be analyzed, and you need at least a minimum batch of 8 samples to be assessed. Once your raw data is available, it's not that you will get a diagnosis on your own. You have to put your data on DKFZ classifier, which has been this thing made by the German group. And this data is, this platform is freely available. It's a classifier tool and it's based on artificial intelligence. And once you put your raw data on this classifier, a PDF report is generated, which gives you tumor molecular subgroup, DNA copy number profiles, and MGMT promoter methylation status. So now, if I look at this platform, only 94,000 cases have been assessed on this platform till date. And this platform is actually undergoing further development. Now, for a good methylation analysis, the tumor content of your tumor should be 70%. And the classifier has given cutoffs. Like if it gives a cutoff of more than 0.9 for class family and a cutoff of 0.5 for a subclass, then only you will consider your diagnosis to be accurate. But this problem is not with us who are generating the data, but it is with the classifier. It is the suboptimal performance of the classifier. So what about the cases in which the classifier fails to reach this cutoff? Those are the problematic cases. There you have to correlate whatever the classifier report is available with your histology, the molecular data available with you, and your immunohistochemistry results and radiological findings. Cost per test is around 40,000 for a fresh frozen tissue and 60,000 for formalin fixed block. But again, you have to wait till the company has 8 samples. That is the minimum thing. And additional cost of 21 lakh is required if you do not need the, array platform. If it is available somewhere, you can use that. But if you want that machine, then it is 3.7 crores. Now the tumors which have been analyzed in very much detail are medullos, meningiomas, ependymomas, and gliomas. Now, if I look at medullos, ATRTs, and pineal tumors in 2012, based on genetic and transcriptome profiling, 4 subgroups of meningiomas were given: WNT, SHH, group 3, and group 4. And on methylation profiling also, these groups were confirmed. But now, in 2021 classification, 12 subtypes of medullos have been introduced based on methylation classification, with 4 subgroups in SHH and 12 subgroups in group 3 and group 4. But if you read these papers on the basis of which WHO has introduced this classification, there is total statistical limitation. These are retrospective patient cohorts with heterogeneous treatments, and only small number of patients have been included. And this is a very nice study in which 79 medulloblastomas were assessed on DK-YZ classifier, and 25% cases failed to produce a confidence score. So in my country, I am not ready to take up, a platform where the failure rate is 25%. After all, it's, patients' money. So I would rather go in for the economical strategies, which have been discussed by Dr. Chitra Sarkar yesterday. And look at these ATRTs again. 3 subgroups have been introduced by WHO, namely TYR, SHH, and MIG, but there is no prognostic information available. The differences in response to current treatments needs validation, and there is no subgroup specific treatment options. So will I use it in clinic? No, I would rather use my humble IHC. This is another, methylation classification for pineoblastomas, which have been introduced in WHO, where they have recognized 4 subtypes of pineoblastomas with worse prognosis in pineoblastoma RB and MIG. But again, the patient number in these studies is very, very small. And these are the data I'm showing from those studies only, where they say that patient number is too small to draw final conclusions or statistically validate the observed results. So then how WHO is, giving a good or bad prognosis? Now coming on to the ependymomas. In ependymomas in 2016 itself, the classification, the methylation-based classification was introduced and 9 molecular subgroups were identified. Now in 2018, there is a study in which 122 adult patient ependymomas were analyzed on the methylation classifier. And in this study, the authors have accepted that they did not find any survival difference between these subgroups because the patient number is small, the lack of follow-up and proper follow-up is not available. This is another study on 113 ependymomas, where they analyzed supratentorial and posterior fossa ependymomas. A lot of heterogeneity was, of course, observed in the supratentorial ependymomas, but they failed to find any survival difference between RELA fusion positive and negative cases. Secondly, the classifier failed in 11% cases, and wrong diagnosis or no diagnosis was given in another 8.3% cases. Further, this is either irony or a discovery. 5 distinct subgroups have been introduced in posterior fossa B. 2 major, 9 minor subgroups have been introduced for posterior fossa A. But my question is, if there is so much heterogeneity within posterior fossa A and B subgroups, if there is no significant difference between the RELA fusion positive and negative subgroups, if there is questionable performance of the classifier, why do we want it in the clinic at this juncture? So I would rather go in for the IHC and FISH platforms, which have been discussed yesterday by Dr. MC Sharma. Now look at meningiomas. Again, there is a remarkable study in which 497 meningiomas have been analyzed. They have subdivided meningiomas into 6 methylation classes. But again, these are the limitations discussed in the paper itself, where they say the follow-up is available only in 46% cases. The progression and treatment response was not uniform. Pediatric meningiomas, of course, needs further evaluation. And this is a study from my center. We have analyzed 35 meningiomas. Of course, to us, methylation profiling has given us many insights, and we could divide meningiomas into 4 subgroups with variable prognosis like malignant, intermediate, benign A and benign B. But When I used this data, my raw data, and I checked the performance, not of methylation, but of the Heidelberg classifier, it failed in 28% cases. So I need answer to the failure. Now, look at the gliomas. This is a comprehensive study of 222 patients in which the authors themselves have written that epigenetic classification is not sufficient for pediatric low-grade gliomas. When they compiled data from 3 centers, total failure rate of the classifier was 50%, and astonishingly in 10% of pediatric low-grade gliomas were termed non-tumor by the classifier. And when we divide like Paxa from other tumors on the classifier, there was no difference in survival. And in Paxas also, it was the grade of the tumor which was statistically significant when they compared with the classifier. So these are lines from this paper only, where they say that in pediatric low-grade gliomas, methylation clustering alone has major issues in reaching high confidence calls because cell population is diverse in a patient with pediatric low-grade glioma. Now you look at another study in which 306 cases were taken in the diagnostic cohort and 195 cases in the archival cohort. And in this study, the failure rate was 51%. And there is 48% failure even when the probe failure is less than 1%. So even in optimal conditions, the classifier is failing. And look at this graph. The best performance was given only in cases where the diagnosis is known. And now, when I compiled data from this study, failure rate varied from 25% to 67%. So we need answers to all this. And there was only moderate performance of this classifier for MIC-C and MIC-N amplification. And in this study, the authors have written that in only 4% of cases, it would have affected the standard management. Now, when they reviewed their 195 cases, and methylation profiling could not resolve 32% of their cases. And this is another study on diffuse gliomas where only 76% cases were assigned a definite diagnosis. Another study on 325 cases with 44% failure. And these authors have discussed in detail about, turnaround times. And they have also given a strategy which they are using for gliomas. And using this strategy, the cost is only 10% of methylation cost. Another study, interesting study on 502 CNS tumors, where they discuss benefits and challenges of methylation classifier. Again, total failure rate was 32.9%, even when the tumor content was between 60 to 100% of most of their cases. Age of tissue block was also optimal. And look at this. A low confidence was given even for tissues which had, good cell percentage, good DNA, good tissue block age. Tumors were not rare. Germline mutations were not there. So we need answers. Why is the classifier failing? So misleading results were given even when the score was more than 0.9% in 6 cases. And this is very interesting study even done by this Heidelberg group only, where they have combined results from 5 centers. Failure rate was between 4 to 44%. So I would conclude exorbitant cost of methylation array at this juncture, relying on an AI-based tool when we do not have answer for any therapeutic intervention. I would rather use this platform as a research tool and would not go in for routine clinical diagnosis because of the problems I have discussed. Secondly, long turnaround times, batched assessments, and so it is better to use this technology as research platform. And rather, we should all get together, do some research with the Heidelberg group, and we should write multi-institutional projects and try to improve efficacy of this classifier. We are dependent on this classifier. It's not that we can generate our own reports. So till then, as a poor resource constrained country, we should rather work towards developing our own minimal methylation classifier, which is based on few genes. Can we work towards that? I feel at this juncture, we are in a state of unconscious incompetence. And we, as I've discussed, need multi-institutional studies. And my take-home message is that, to my mind, whole genome methylation from lab to clinic, its performance is questionable at this juncture. Thank you.
Thank you, Vaishali, for your usual passionate. I'm glad there are no Germans, Heidelberg people here in the audience. But
So I had a debate with that group.
I remember, no one can forget that report, that debate. Who can forget? So very interesting, but very fascinating also. In the morning, your student also presented very well on the meningioma. So one question
Yes, sir.
and one comment, and I'm sure Sridhar will have hundreds of questions for you. First comment is, because it is new for us, why do you need this DKFZ classifier?
Sir, there is no way to generate a report. If you want one-to-one report, every person in the world is dependent upon the DKFZ
So
classifier.
who owns this methylation platform?
The Heidelberg group.
There is no other company in the world?
No, not at all. No, even US people, everyone. So right now, sir, it's a free platform, but from maybe another 2-3 years, they are going to make it paid. Even putting your data on the platform.
So that
you
is
have
the
to pay.
classifier, but the actual platform, where do you get it done? Here?
There are very many companies, sir, like MedGenome.
So you
is there.
outsource it? Or?
We outsource it, but they want like I now want to do it on formalin fixed tissue samples. It's a
Right.
research project. They said, only if you, madam, promise me 48 samples, that to 60,000 per sample, but they will only give me raw data. I mean, I can do unsupervised clustering. I can see where they're lying, but if I want one by one report, so I mean, like some meningiomas were classified as coral plexus tumor, some is normal tissue,
Okay.
like haywire reports
Yeah.
are there. And in some cases, they are giving three reports. Where do I classify them?
It appears, I mean, David Louis was a little bit defensive yesterday, as you can see. I'm sure he must be bombarded with all those questions, and he put on FAQ before we started bombarding him. And I'm glad you didn't ask any question. But what I want to ask you is, therefore, it seems that WHO CNS5 was prematurely
Yes,
putting so much
of course.
emphasis on methylation.
Yes, yes.
It's a unequivocal yes. They were
100%,
premature.
sir, I am very sure.
100%. Yes, Sridhar. I know you are waiting. You are itching to go to the mic.
So one thing I wanted to, what Vaishali, I heard her before also, I think what every one of us feels, sees the voice of it, she can appeal to very strongly. And I think what she makes is very much applicable for our kind of setup, no doubt about it. But at the same time, if you hear Dr. Lewis yesterday's lecture, it's as actually quite awakening to us to understand that it's learning. That Heidelberg is a classifier. It's an artificial intelligence based an app, or it has been created. It's continuously evolving. The more the number of files Dr. Vaishali is uploading, it is helping that classifier.
Yeah.
The thing why it has come is one is when the Heidelberg group was the first group who worked on methylation earlier in 450K data, then later on the Canada group and St. Jude group and all. So together initially when they had a very initial classifier developed, they together held it. And to now and current situation, no other group has such enormous methylation data with us to compete it. So that's what she wanted to say, that if you want to develop your classifier, you need to have maybe 10 times more. If you are saying she showed about 1 lakh cases, tomorrow after some years when they have 10 lakh cases, their classifier will have a different amended.
No, we are not disputing the science behind it. Science is there.
I think what David Liu highlighted one statement, if you remember that, I was fascinated by his equation with histology. You take 100 things, assimilate in your mind, and you talk about. That's pathologist. What a Heidelberg classifier is, it is assimilating the data and producing a robotic type of map, that will keep on changing.
No,
so today we are
sorry to interrupt you, because we have to. I know what you're saying, and science is there. But what our question is, and I think Vaishali says the same. What is so urgent need to bring it to WHO CNS5, which we are grappling even with IHC and molecular? What is so urgent? There is what Dr. Ashish was telling me. Maybe there are some other issues behind it.
Personally, I'm not in the part.
Why? No, it's not personal. As a pathologist, because
I'll tell you what. So,
I told you a little bit about atypical meningioma, and you just bandwagon.
No, I mean,
you are defender of neuropathology.
It's like half glass full. You want to say half glass full or half glass?
No. Why?
Why? I'll tell you why. Today, if you have a mechanism to say that these tumors are different, and you still don't want to acknowledge that these tumors are different just because we can't do it, is it a right way? Or we to accept it?
I think the question is simple. Do we have enough evidence and confidence of neuropathologists all around the world? Because WHO is not run by Germans or Americans. WHO is World Health Organization. It's for the entire world. Do we have enough evidence, scientific, as a scientific question, not a political question?
I agree with the evidence.
What is so urgent, burning need to introduce into the CNS?
So 70% of the cases where you got the data,
30 to 35% you have no idea.
We're not talking about failure. I'm talking where you got the data.
Wait for 5 years. Let people go 10, 20 lakh cases.
It's premature.
Do a multi-institutional collaborative study. Build up a robust AI system. Then you introduce slowly. Maybe not even the next 6th, 7th, 8th classification you can.
I completely agree with it. But we have to be a little bit intelligent, sir. WHO classification is classification. It doesn't tell you that you use that classification into your routine treatment model. That serves as a kind of there. Okay, we can classify, fine. It does not tell you. So today, do you have a protocol based on WHO entity treatment?
Yes.
No.
There are several. I mean, WHO classification for
entity-based
tumors has a rich history. Not only
WHO classification does not wait for the treatment protocol to evolve and introduce. They classify tumors as and when you get enough biological evidence to be, or a clinical data evidence to be as a distinct entity or subgroup.
Okay, I have to stop it. I have to draw your attention to David Louis' introductory slide. First slide. He showed WHO is absolutely critical because it changes the treatment, the care, the clinical trials. We are only and solely dependent on you.
Yes.
On the
last
WHO.
Point I agree. It gives you a very meaningful guidance for the clinical trial.
No, but for the treatment, that was his first statement. Then he went to the epidemiology, then he went to the population base. So it has a big bearing. So it is the onus of the neuropathologists of the world not to thrust upon a technology or science which is unproven.
Sir, my humble request is, do not use it for...
Humbly need strong request.
Strong request is, do not use it on day-to-day single patient-based basis. Like now I have got an ICMR grant where we'll be analyzing 100 pediatric and AYA patients. So let us start doing that slowly.
No, it has to be done. There's no doubt. It is probably the future, but it was, I think, premature to introduce
it.
That but just for the sake of discussion, don't mind or don't get angry. If I can ask you the same for proton and photon therapy, do you have the kind of typical kind of evidence to introduce into the clinics? Maybe that's debatable.
No, they are two difficult, completely different. By the way, there was a randomized trial presented this morning. Landmark study. So that is a different story. I mean, we have to accept unanimously that was a little bit premature.
Thank you.
I just want to say one thing. I think the benefit of putting it in WHO, I think the benefit for a pathologist or data clinician is, right? You have seen impact for all these years. So a person who's
my voice is loud. So impact, sir, people who are only working in neuro centers, pure neuro centers would have come across impact. Not everybody came across impact. So when you put something in WHO, each and every postgraduate, everybody at least gets a hint that this is the future.
No. The thing is, don't make it a desirable or essential criteria.
That I agree. That I totally agree. But what happens is, like from the previous CNS WHO to this, a person who was not reading what this was like out of the blue. So if they add something to the WHO, it at least opens your eyes that this is happening across the world, and maybe in near future, it might be applicable. Though, of course, making it essential is not what I would also recommend.
But that's what we are saying. I know what you mean. It's an education exercise. But the primary of WHO is not like that. Primary aim of WHO is to guide people in the daily clinic. Okay, we have to end this fascinating debate. Thank you again, Dr. Vaishali, for bringing up the subject. And continuing in the same vein, again, a rather little bit controversial subject, is my pleasure to introduce to you my colleague, Amitava Ray, who's a senior neurosurgeon from Apollo Hospitals in Hyderabad and is passionate about liquid biopsy. So we are waiting for liquid biopsy to come into WHO CNS 6. And he will try to convince us why it should be in the CNS 6. Amitava, floor is yours.
Thank you very much for invitation, and Dr. Jalali, thank you for the introduction. I am just so happy that we had a debate on methylation, because most of the time it does not work. I have been trying it for the last 2 years, and as a part of my liquid biopsy project, and we have actually moved from doing methylation to whole genome, because I think there is a lot that still remains unanswered. Okay. However, my talk is on liquid biopsy, and I'm supposed to be asking better questions, and I hope I do. So I sort of fell into liquid biopsy because of a patient like this who I lost while doing a biopsy. And it was about 10 years ago, I think exactly 10 years ago, 2012. It was Diwali night, and I was doing a biopsy. The son was in San Francisco. He came for his mom's biopsy. And what happened was, nothing happened during biopsy. We took a little bit of tumor, and it all went okay. And I was getting ready for my Diwali party when I got a call saying that she was, people had blown and she was unconscious, and we went back in. And we took out the clot, but it was a deep left-sided lesion. For the next 3 months, what went was lit up in this slide. Okay. She died finally 3 months later, and it was complete hell for her, for us as treating physicians, and for the family. At which point you always sort of introspect and you think, is there something I'm doing wrong? Am I the worst surgeon of the lot? And you're not. And if you look and if you see what data, the data I think is before we had all the frameless stereotaxy devices, et cetera. But even people like Raymond Savaya, who were doyens in clinical oncology, have got a death rate, a mortality rate. Okay. So, as they say, bad things do happen, and you just have to do enough for bad things to happen to you. And this sort of opened my mind, and I was starting to look around, and and one thing that always comes to mind is, of everything else, heterogeneity is something that we always go on about when we talk about glioblastomas. Well, and this is a slide that from research which I did, and it's the same tumor. Okay, and actually the right side, the one with no red lines, is the center of the tumor, and the left side is the periphery of the tumor. Actually, that is the bit of the tumor I thought was normal. This was about a centimeter away from which I thought was at the edge of the tumor, and you can see that the number of active sort of cancer-causing pathways a centimeter away from the tumor is far more than that of the center. So the active edge is always progressing. And when we looked around, we found that this is something that is not specific to brain tumors, okay? Hepatobiliary cancers, lung cancers have a lot of heterogeneity as well. And it's just that they don't go on about it that much, okay? And we also found that the molecular profile for the same cancer was different. Now, 10 years ago, if you look at the landscape 10 years ago, there was GBM, okay? And the paper that said IDH mutant GBM consisting 10% of GBMs do well had just come out, okay? So that was the landscape at that point. So when we started this, that was the landscape. And Dr. Suri, I completely agree with you. Everything has changed except for the neurosurgeons. So we have this varied molecular profile, and this also struck me that maybe GBM is not GBM, but it's a collection of several things that just look similar. Okay. And we also found out that during therapy, okay, the molecular profiles change. And that happens not only in brain tumors, but across all tumors. And this is actually from breast cancer. So in breast cancer, we found that there is a change from HER2 positive to HER2 negative. And I was speaking to some of my breast cancer colleagues, and they said, yeah, this happens quite frequently. So we thought, okay, so is there a system that we could sort of implement that would take everything together? It would reduce the risk, and it would improve the way we diagnose tumors, okay? And again, 10 years ago, there were mainly three things. I think there are still only three things. There was cell-free DNA. Actually, cell-free DNA has been described about 50 years ago now, and it is now in common use in a lot of other cancers, and we should see later. There is the circulating tumor cell. So circulating tumor cell sort of fell off in the middle because people said we don't see so much of circulating tumor cell. But with this single cell transcriptomics, now again, single cell seems to be the flavor of the day. But I was really interested in these things called exosomes, which are nothing but little vesicles that come out of live cells. Okay. And initially they were thought to be poop or garbage that the cell sort of just got rid of, but now we know it is far more than that. It plays a lot of role in the way the cell behaves, in the way the tumor behaves, in cell-to-cell signaling, in distant metastatic disease, etc., etc. So we started looking at exosomes as a platform we could use to diagnose brain tumors. Okay. So why liquid biopsy? I think if we sort of look at it and think about it, it's quite, it is quite obvious. It is simple, it is simpler, it is safer, and there is minimal pain. I mean, people told me there is no pain. Well, no, I have had blood taken and it does hurt. So there is minimal pain. It does capture heterogeneity, okay? And it is specific and sensitive, and I will show you some of the data that we've got now, which supports what we say. And the other thing is, it is possible to do a blood test every day. Okay, it's not possible to do a brain biopsy every day. So if we could make this move from doing biopsies to doing biopsies, then following up with liquid biopsies, then maybe we will have an answer. Okay. Last year, 2020, the evaluation of genomic applications came out with guidelines that says analytical validity, clinical validity, and clinical utility are a must for any liquid biopsy test. So analytical validity and clinical validity are slightly different, but analysis means that your test has to hold. Clinical validity means you have to be able to clinically identify a cohort of patients in whom you will do the test. And obviously, clinical utility means people doing the test should do better than people not doing the test. And if you talk about unavailability of tissue samples, it happens elsewhere as well. It's not something that is particular to neurosurgery. And this happens in hepatobiliary cancers. And this is a paper that came out in 2015, okay? And we can see 35% of tumors, okay, either not available or inadequate. Okay, concordant results 90%, diagnostic accuracy 97%. But even here, we find that people do not always hit the tumor. So there is a lot of concordance between EGFR mutations and small cell lung cancer, so non-small cell lung cancer. And this is a paper that I will not get into. But if you find it, it's very specific. It's 100% specific. Okay. And we've also found that tracking mutations of ctDNA predicts relapse in breast cancer. And all these are actually now established, okay, including monitoring therapy resistance. So in every stage of cancer, we have found that there is a growing body of evidence that seems to say that liquid biopsy is an option. I will not say an answer, but an option, okay. And when we started 2013 14, these were all the papers that were out. It was being used in colon cancer, in ovarian and liver cancers, in primary cancers of the brain, prostate, brain not so much, but thyroid, advanced breast cancer, and obviously non-small cell lung cancer. Okay. And if we look, we sort of wind the clock forward and look at 10 years from the point where we started, now we have multiple tests that are actually FDA approved. Some of them are CLIA approved, and a lot of them are state approved. Okay. And there are a lot of people who are doing this right now. Okay. So we did a first study that was just to see if we saw EGFR in brain tumors, okay, in the exosome. Okay. And this was published in the Journal of Neurosurgery. And if you look at it, there is a very interesting thing. If you look at the top row on the left side on the black X-ray thing, you will see that EGFR wild type is seen in the tissue, but not in the exosome. So exosomes do not always contain all the markers that the tissue contains, But the splice variant, or the EGFR V3, which is a much smaller molecule, is almost ubiquitously seen in the exosome. So this is a very interesting finding. Okay, and we found that, yeah, if you had exosomes in your blood which had EGFR, then you did worse. Okay, we went on to do a model which didn't really hold very much, because by this time IDH had become one of the major players, and if you do a blind model, then IDH doesn't show up. The most interesting thing was, and this was pre 2016, so we didn't have all the classifiers that made low-grade tumors into high-grade tumors, like EGFR in the blood, and chromosome 7 amplification, chromosome 10 loss. So all these things were not there. And at that point, we found that it was probably a good tool to look at low-grade tumors that would do worse. Okay. And this is, Dr. Suri, your favorite slide. It's on methylation. This is the methylation sort of patch of all the brain tumors. And if you look at sort of the bottom left, you will find that there are the 7 classifiers of GBM. Okay, right at the top right in yellow, you have the IDH mutant types. And these are very different. They are separated by an ocean of other things. Okay, how this happens, I do not know, but this is how it happens. Okay. So we started about 2 years ago, and I wanted to do this from scratch to see if we could come up with a test that would work across all tumors. We are still in gliomas, and what we did was, we tried to increase the number of points that we use for diagnosis. So we are now doing a whole exome, total RNA in the tumor, along with a total RNA-seq of the exosome in the blood and the germline. So we've got a lot of data coming out of each tumor, okay? And if you look at it now, we have about 1,300 genes that are upregulated in both, about 1,600 genes that are downregulated in both. I mean, both means the tumor and the exosome. But the interesting thing is here, and this just came out in Neurology India. Somehow we feel that suppressor genes are overexpressed in the exosome. Okay. Is this a way that the tumor gets rid of P10? Is this a way that the tumor gets rid of P53? Okay, so expression levels of suppressor genes in exosomes is twice that of what is found in the tumor. I don't have an answer, which is just an observation. Okay, and this is some data, right? This is some data, this is some raw data, this is some 10 samples that I just pulled out, right? And you can see this is just a plain PCA plot. So no identifiers, nothing, just a blind PCA plot. And you will see that there is a, sorry, how do I point? Is there a pointer here? Anyway, so if you see on the left-hand side, right at the top, you have a little cluster. Okay, so there is a little cluster here of all the IDH wild-type GBMs. Okay, and you've got these two, right, which are sort of far away. And you look, there are 2 IDH mutant tumors in this. Okay. So it actually does classify, it does happen, okay? We're still not there. We've got about 100 samples that we've done now. And everybody in this room, there are a lot of people in this room who really helped me do this. And thank you from the bottom of my heart to all of them, okay? But it does happen. And I think, in the next few months, we will probably be able to publish a data at least on glioblastomas. And it is interesting that we do find at least 5 of the 7 different classifications, methylation-based classifications of GBM in gliomas. Okay, and we are not the only ones. I mean, there are a lot of people around the world who are doing it. It was very interesting because the first paper was actually posted on the WhatsApp group that we have, the ISNO WhatsApp group. And Paul Brennan and company use spectrophotometry to do this, okay, and they're very, very accurate. We've had a number of papers, especially on meningiomas, that have come out from Toronto, from Gallery Zadeh and Nasiri's group. So a lot of papers coming out on exosomes right now, and obviously circulating tumor cells have been there for a while. There is now a liquid biopsy consortium that has been formed, and it is now part of both the Society of Neuro Oncology and the European Society. So, you know, we are trying to say that, yes, we have a voice here as well. Okay, we are still fighting, but we will see. So there is a society that is formed, and there's a lot of collaboration happening across centers to get this, to make this happen. So thank you once again to the organizers, and keep your eyes peeled for what happens next.
Fascinating, very nice. Any questions or comments, please?
Now, Dr. Amitava, you are taking the blood samples from the patients you are operating with gliomas, right? And many of them are grade 2 tumors also, right?
Yeah.
And so what is your finding? I'm not very sure about it. I mean, are you able to conclude that you are able to diagnose by the liquid biopsy?
That's a difficult question. Let me just rephrase what I say. Okay. So in higher grade IDH mutant glioblastomas, I think the specificity and the sensitivity are very high. When I say very high, they're in the high 90s. We have not got that many lower grade tumors to be able to come up with that kind of specificity and sensitivity. But we definitely think we can tell you if it's an oligo or an astro, even if it's a lower grade one. Okay, because you know they cluster at different points. Okay, and it gets harder as the grade gets lower in gliomas, but not in meningiomas for some reason, which we do not know the answer to. Meningioma patients have exosomes filled with a meningioma fluid. Okay, but lower grade astros, pilocytics, some of the pilomyxoids do not, and I do not know an answer. We do not have an answer to that. But I think maybe in the next 5 to 6 months, I'll be in a better position to answer your question.
The most common brain tumor is GBM, right?
Right.
So I think they are the ones who throw exosomes to the blood,
right,
mostly, right?
Right.
So in our institution, we are also trying to do liquid biopsy, taking all these primary glioblastomas, we take out wherever it is possible, CSF as well as blood. Though the data has not been analyzed yet, but I was happy to know that you are also doing the same.
Right.
So we need to find out whether it will be ever possible to just diagnose even GBM, which is a formidable disease, by just blood or by CSF sometimes, because CSF you can take out better than going to surgery.
So, I have actually stayed away from CSF because if you want the test to be widely used, it has to be used by GPs and neurologists, and I do not want a GP doing a lumbar puncture on a patient with a brain tumor.
No, that's fine, but I mean,
but coming to your point, the exosomes in the CSF are 10x that of blood. Okay, so if you don't get it on blood, definitely on CSF you get it.
I think this was very nice paper and very nice.
Sorry, your talk. Yes.
Yeah, I congratulate you for one. I think it's a very promising thing, and maybe I think you still have research-based some opinions at the moment. But I think now 10 years, some light will be there. But I think the model of your lecturers don't operate on Diwali night, an elective surgery of an octogenarian. So that is, I think, and second, I think most important, glioblastomas with the present MR technology, with earlier it was MRS, and now we are talking about perfusion, and we are going towards MRE as well. Now, Mayo's I think we are going to start MR elastography. Mayo's already. You can actually go into, you can actually predict even the IDH status of the GBM tumors. I think with that technology that we are going in for imaging, at least if a patient is 80 plus, I don't operate glioblastomas after 80 now. I send them directly to my radiation oncologist, and either if we don't have a date, and they send it to Tata, we send it to Tata for direct radiation. I think GBMs can be directly predicted to a lot of more near 99% accuracy on radiology. So I think rather than operating or even liquid biopsy, this is a promising technique, but it will take another 10 years.
So I think this is a start. I mean, we have to start somewhere. Yeah. One of the things that our radiation therapists, there's nobody here, they do not radiate without a tissue biopsy. Okay, so we are often forced to do this.
That was earlier. Now the things are changing for glioblastomas, not for lymphomas till now. Lymphomas, medical oncologists are not giving a medical therapy unless you have a tissue biopsy.
Yeah.
But for GBM, the trend is changing.
But so, Dr. Rakesh, will you radiate somebody without a biopsy?
Well, occasionally we do, but rarely.
Yeah.
In a midbrain or thymus or somewhere occasionally. But prognostically, I think it will be very interesting, like we do for the prognostically in future as a recurrence. Dr. Pathak has a comment, but I want some biologists or scientists to ask some questions. There were some very bright ladies there in the hall B. Yes, please, Dr. Pathak.
Now, you talked about the difference between the GBM and the low grades. Now, there's this blood-brain barrier, which gets widely disrupted in the aggressive tumors, but less disrupted, I believe so, in the low grade. So, probably your results and the findings would vary as per the invasive nature of the tumor and its aggressiveness.
So, exosomes are actually actively sort of pushed into the bloodstream. Okay, it's an active process by which it goes into the bloodstream. I think you have a point. I think you have a point.
For the brain tumors, because other rest of the body tumors,
it's
all free. So that's
so I think you might have a point, because that's what the data seems to suggest, that if the blood-brain barrier is properly broken, then the number of exosomes is enough. Okay, but having said that, if I just showed you 5 tubes, normal, low grade, intermediate grade malignancy and high grade malignancy, and if I just showed you the exosome, the pellet that forms, right, as a result of, you could just look at it and say, oh, this is malignant, because the amount of exosomes that really malignant tumors produce is, I think, 40x that of the normal ones. So it's huge, so you almost don't need to do a test. You could just say, yeah, right, this is malignant.
Can I ask you one very fundamental question, very
Sure.
basic? You mentioned there's a good correlation in meningiomas. So you remove a meningioma, after a month you do the test. Would you still get some exosomes in the blood?
Don't know, but I think, so one thing that we know is when the tumor is growing inside, we get a lot of exosomes. So once the tumor is taken away, the amount of exosomes fall. That is normal for normal tumors, okay, but that is not for meningiomas, okay. One of the things about meningiomas, and I completely agree that 9% of meningioma, grade 1 meningiomas come back, okay. And as surgeons, we always grapple with this, right? How much do we do? Okay, we do what is safe, right? But do we, there is always, at least I have this thing of, okay, do I just leave that bit, or, do I go that bit further, okay? And I think it would actually help if we could have a guide. Okay, this is aggressive. This is going to come back in a month. Okay, you better go and do whatever you can, and you accept the deficit.
Yeah.
Or you say, well, I mean, this is going to be quite benign, and we are not probably looking at a recurrence in the next 7-8 years. I mean, she's a 30-year-old. Okay, just let her be. So I think that is very interesting from a surgical point of view, to be able to say that, yes, it helps in decision making, and whatever technology we try and develop, if it does not move the needle where the patient is concerned, it will fail. Okay, it is, and that, I think that is sort of the bottom line.
For adjuvant therapy, it would help. I think one final question.
Yeah, well, we have not got brainstem gliomas, but we've got HCK27M positive thalamic gliomas, and you can see HCK27M quite nicely.
You can see.
Yeah. Yeah, IDH and
I think HCK27 will be very fascinating, because we hardly ever do biopsies.
I don't know the answer to that, because I actually have been cheating. So basically, and the other thing I would say is that, so we have now collected close to 1,400 samples from across the country, from small hospitals in Warangal and Karimnagar and Medak, to large hospitals like the Apollos and the Medantas. And the pathological reporting is being I want to publish that. When we compare to our whole genome profile, it's 98.7% accurate. So I think a round of applause for the pathologist is in order.
Thank you very much.
Yeah, last question is here.
Yeah, sure.
What's your take on oncometabolites? Because again, diagnostic and prognostic, there is a significant role of liquid biopsy. What's your take on oncometabolites? Especially in GBM.
So I actually don't have a take on it as such. Okay. Yes, I mean, you find them in exosomes as well, right? But are the levels significant enough to make a diagnosis just on the basis of oncometabolites? I don't know. Okay. What we are trying to do is make it useful. Okay, make it useful for everybody. So, and to do that, I think, that is a bridge that we, I don't think we're addressing it right now. I don't think we're addressing the question right now. We are actually quite far away from that.
Okay, thank you very much, Dr. Amitava. It was a very nice talk. And now we have come to the last talk of the session as well as last talk of the meeting also. And this is recorded talk, and this will be given by Dr. Pantaleo Romanelli. He is a cyberknife expert, and he is the scientific director of the brain radiosurgery at Cyberknife Center, CDI Milan, and where he is treating more than 1,000 cases per year, which is a huge number. And he's a neurosurgeon, and he has had a training in strategic neurosurgery at NYU, New York, and Stanford. And he has more than 70 publications, 4 patents, and he has authored a book. So now, can we play the talk?
Good morning. It's a very great pleasure to give you this talk. I am so sorry not to be there in person. So it's been a great pleasure to be there myself. We talk today about a non-oncological application of stereotactic radiosurgery, so the radiosurgery beyond tumors. In the specific case, we will talk about image-guided robotic radiosurgery, meaning cyberknife radiosurgery for trigeminal neuralgia. Functional radiosurgery, which is treating functional disorders of the brain, is an emerging field in radiosurgery, and the number of treatments we are doing on functional disorders of the brain using radiosurgery is increasing daily. To tell the truth, radiosurgery was originally developed by Lars Leksell to treat, with the aim to treat functional disorders of the brain. And the very first case of radiosurgery reported by Lars Leksell in 1951 on Acta Chirurgica Scandinava, as you can see below in the citation, was performed on a trigeminal neuralgia case. Trigeminal neuralgia has been treated with radiosurgery for the last 40 years, mostly with gamma knife, and the emergence of LINAC techniques such as cyberknife has allowed to treat radiosurgically this disorder, trigeminal neuralgia, also with linear accelerators. Then there are extensive reports in literature. But today, radiosurgery is also being used for other kind of pain, for epilepsy, for movement disorders, for psychiatric disorders, and an emerging treatment is spasticity. Here on the right-hand side, you can see Lars Leksell performing a stereotactic radiosurgery procedure using proton beams in the early 60s. Lars Leksell was, as you all know, an extremely bright scientist and physician, and he invented and developed the field of radiosurgery first. He was a neurosurgeon at the Karolinska Institute in Stockholm, mainly. In this report, which was published on the Journal of Neurology, Neurosurgery and Psychiatry in 1983, he shows his activity between 1968 and 1982 And you see that he performed several cases of functional radiosurgery, hypophysectomy, 24 cases, intractable pain, 83 cases. In here, the target was the thalamus, was a radiosurgical thalamotomy, trigeminal neuralgia, 63 cases, anxiety and obsessive compulsive disorder, 26 cases, and Parkinsonism, 5 cases. So you see that Lexell already had an extremely important experience in functional radiosurgery. So when we go to trigeminal neuralgia, we start from the extensive experience of gamma knife users treating trigeminal neuralgia. The limits of gamma knife are that a static frame is required, so which is quite unpleasant for most patients, and you are restricted to a single isocenter. Using 2 isocenters, like reported by Flickinger in a very known paper, using 2 isocenters caused a strong increase of toxicity. In this paper by Jean Reggie from Marseille, there is a report of 15 years of radiosurgery using trigeminal on trigeminal neuralgia, using gamma knife. On the graph on the right side, you see the very strong increase of the number of patients treated over the years. It's essentially an exponential increase. Frameless radiosurgery using image guidance with the CyberKnife, developed by John Adler at the end of the 90s at the Stanford University, allowed to introduce a novel treatment modality, so treating in a non-homogeneous way an extended segment of the trigeminal nerve, so in this case 6 millimeters versus 4 millimeters, which is what is allowed by the isocentric treatment done with gamma knife, which fits very well to treat the trigeminal nerve. And today, frameless image-guided radiosurgery for trigeminal neuralgia is surely the less invasive treatment for this disorder, the others being frame-based treatments using radiosurgery, percutaneous procedures, or microvascular decompression. So the CyberKnife is a robotic system with an image-guided system allowing frameless treatments. The treatment planning is non-isocentric inverse treatment planning. And we use this device to do the first trigeminal neuralgia treatment at Stanford in the early 2000s. I introduced the standardized protocol at CDI in Milan in 2009, and since then we have treated close to 1,000 patients at CDI with this protocol, which delivers 60 gray to a 6 millimeter retrobasilian to mid-cisternal target. And we have published intermediate and long-term results. Intermediate results were published on neurosurgery in 2017, long-term results in Curious in 2018, and we are close to publish 10 years follow-ups very soon. So in this paper, published on neurosurgery in 2017, you see first on the right hand side at the bottom, you see the targeting. So here you see the retrobasilian to mid-cisternal target, which is used for the treatment. Here you see the beams, which are non-isocentrically converging on the target. And on the bottom, you see the sagittal and coronal view, while on the top, you see the axial view. So in this paper, we prospectively followed the 138 patients. They received a prescribed dose of 60 gray. and essentially they tolerated the treatment well. Around 93% of the patients was pain-free after 6 months. And they remained pain-free after 36 months with a 76% rate. 33 patients of this cohort, about 24%, required a second treatment to keep the pain control. Recurrences happened on average 13 months after the first treatment. A relatively small number of patients developed hypoesthesia, 18 patients overall. 11 patients of them had 2 treatments. So in 11 out of 18 patients, hypoesthesia developed after retreatment. And essentially, the main factors affecting the outcome were nerve length. So treating 6 millimeters was more effective than treating less than 6 millimeters. Small nerve volume with volumes of 30 cubic millimeters being more effective than volumes less than 30 cubic millimeters, and lower doses. So doses above 58 gray were more effective than those below 58 gray. So overall, the conclusion of this paper is that targeting a 6 millimeter segment of the trigeminal nerve with a prescribed dose of 60 gray was safe and effective with long-term pain control and a minor risk of sensory complication, typically happening after retreatment. So this shows how we describe the complication using the BNI pain scale with score of 1 meaning no pain, no medications, score of 5 meaning severe pain or no pain relief. We also assess these patients using the VAS score. In this paper, we treated the patients having a VAS score of 7 to 10, so very severe disabling pain. Numbness was scored again with the BNI, Bar of Neurological Institute score, with score 1 meaning no facial numbness, score 4 meaning severe facial numbness, very bothersome. And this shows the results on the BNI pain score. So as you can see, after treatment, most patients were in class 1, so having no pain, while before treatment, most patients were in class 4 and 5, so having severe pain. This is again the visual analog score in patients before and after treatment. So before the treatment, most patients had these scores going from 7 to 10, while after treatment, majority of patients had a score of 0, so no pain. So we published after a while another paper where we had 387 cases with 3 years follow-up. And again, you can see the BAS score, the visual analog score, where the patients were starting from very high scores at the moment of the treatment. I am referring to the right-hand side graph. And after 3 months, most patients were pain-free. After 6 months, over 90% of the patients had scores or had pain scores going from 0 to 2, so an extremely good improvement. And this was kept until 36 months. And also on the left-hand side, you see the BNI pain scores going from 1 to 3, meaning good pain control. And while after 6 months we are we are close to 100% pain control. It was about 95% pain control. We go down to about 80% after 36 months. So there is, over time, some patients lose pain control, but quite high number of patients keep it for a long time. So after 10 years, we verified retrospectively on 668 patients, where a standard dose of 60 gray was prescribed to the 80% isodose to the retrogastirian mid-cisternal segment of the trigeminal nerve, a pain control that was pretty much similar to the one we have seen already. So the target included the 6 millimeters of the cisternal segment of the trigeminal nerve, extending from the retrogastirian, so essentially starting from the ostium of Meckel cave region to the mid-cisternal region. The average target volume was 30 cubic millimeters. Critical structures included brainstem, of course, homolateral trigeminal ganglion, the gastric ganglion inside the Meckel's cave, 7 and 8 cranial nerves, cochlear labyrinth, and homolateral hippocampus. Also, we identified the offending cells, which was drawn as well. And it was very common to find an offending cell. The pain relief rate in 343 patients was 92% after 6 months, 87% after 1 year, and 76% after 3 years. At 5 and 10 years, follow-ups available for 84 patients, we had relief rates of 74 and 72%. 17.8% of the patients required a second treatment because of either lack of efficacy of the first treatment in 4 patients, 4.7%, or due to a pain relapse in 11 patients, that is 13.1%. We found non-major neurological complications in this cohort. So only BNI grade 3 sensory complications in 7 and 5 patients after 5 and 10 years, which means hypoesthesia and numbness, which is only mildly bothering. All these patients had 2 procedures. We had 1 patient with BNI grade 4 hypoesthesia with bothering paresthesias. This developed after 2 treatments delivering 60 gray both, and this patient underwent successively a medial thalamotomy, which resolved the bothering paresthesias. So the rate of sensory complications, including BNI grade 3 and 4, after 5 and 10 years was respectively 9.5% and 5.9%. So after 10 years, 5.9% had bothering or mildly non-bothering paresthesias. And this graph shows the pain control after 10 years, which is stable over a little above 70% of the patients treated, about 73% of the patients treated. So in conclusion, frameless image-guided linear radiosurgery for trigeminal neuralgia gives to patients excellent short, intermediate, and long-term results on pain control with a modest rate of sensory complications and no major neurological complications. The only complications we found were sensory complications, including BNI grade 3 and 4 hypoesthesia with non-bothering or bothering paresthesias. We had no cases of anesthesia dolorosa. Sensory complications persisting after 5 and 10 years were found only in patients undergoing a second treatment. 72%, so over 2/3 of the patients treated, are still pain-free 10 years after the treatment. So we use this experience to develop a novel treatment protocol where the target is not the trigeminal nerve, but the spinal roots. CyberKnife allows to treat the spinal targets, or in general extracranial targets. And in my view, considering how precious is the radiosurgical treatment of trigeminal neuralgia, how good overall are the results, and with relatively rare complications, especially if you think of the complications of any other treatment modality, or if you think about other radiosurgical modalities such as gamma knife, you still are using a frameless approach, so again, much less invasive. And so I thought to apply radiosurgery to the spinal nerve roots to relieve spasticity. Spasticity is a huge problem worldwide, and it's essentially a problem that is orphan of treatment because an extremely small number of patients is exposed to surgical procedures which are quite effective, like selective rhizotomy. But again, only a very small number of the patients in the world suffering from severe spasticity receives a surgical treatment. And medical treatment is often not effective. You can also implant an intrathecal baclofen pump, but again, it's a treatment that is reserved only a small number of patients in the world. So I treated a small number of patients with very interesting results, and now we are starting a randomized study to assess safety and efficacy of this new therapeutic approach. This is a paper on 4 patients I treated, and you can see that the patients had a quite substantial improvement on the spasticity scores, which you can see on the left-hand side, MAS score, modified Ashworth scale score, and also regarding the pain, looking at the visual analog score. So in this paper, published in Curious in 2021, stereotactic irradiation of cervical or lumbar nerve roots improved the modified Ashworth scale, the visual analog scale, in patients with severe refractory spasticity due to brain and or spinal cord injury. And this shows the targets. This is a slice of the treatment plan on axial view, showing a cervical root being treated. This is the postganglionic sensory route going, traveling with sensory informations and pain information to the spinal cord. And on the right-hand side, you see a treatment at the lumbosacral level. So this is S1 root being treated, the dorsolateral region of S1, which is the region dedicated to the sensory fibers. And I thank you very much for allowing me to present this data. And again, I am very sorry not being there with you. I hope you will write to me and the organizers can provide you my contacts in case you have any question. Thank you very much.
Thank you very much, Dr. Pantaleo Romanelli. Unfortunately, he is not here to take questions, but I think Dr. Aditya, if audience have any question, Dr. Aditya can answer.
Dr. Aditya, 60 gray, does it sound a little bit lower? That's what he was saying. And can you summarize for all of us, what is the Indian experience? I know Shankar does a lot, you do a lot too. What is the general experience so far?
I think what he described is 60 gray to be 60% isodose, if I understood correctly. So which would make it what, roughly 85 at least, the Dmax, roughly 85 it would put it. So that's an acceptable dose. Exactly, the gamma knife series exactly talks about the same dose range. I think anything less than 70 is completely ineffective. 80 to 90 is good. I personally don't like to go beyond 80 or 85 in any of my patients. I think our results are very similar to what he showed. The only thing is the place of radiosurgery in the management of trigeminal neuralgia has to be defined a bit clearly, because there is definitely a good proportion of patients who are candidates for MBD, which, as we know, is the modality with the best long-term pain relief. Also a good role for percutaneous procedures, which are also relatively non-invasive compared to MBD. But definitely, I would say radiosurgery is one option for the failures of any of the modalities. We get a lot of patients asking for radiosurgery as the first method of treatment, which I personally like to sort of not encourage too much and do MBD rather than offering radiosurgery. So beyond that, I think the target, what he describes, is exactly what we follow. The dosage, what he describes, is exactly what we follow. Brainstem dose, we have to be very, very careful about what dose is going on to the brainstem. In trigeminal, the curious thing is, at least in the gamma knife series, you will find somebody's putting a shot right at the root entry zone. Somebody is doing retroglycerian, and there is a group doing anywhere in between, wherever the 20% isodose touches the brainstem, there they put the shot. So, you know, the variability of target is also there. But I think radiosurgery for trigeminal is a very, very well accepted and very, very well documented technique, very valuable technique.
He's targeted in the system, right?
So he has targeted just behind the Griserian ganglion, which is the standard target which all of us have.
And he also mentioned the treatment by cyber knife about the spasticity.
That is something which is very, very new. I think he's doing it almost like a research study, is what I understood from his description.
Okay.
Randomized trial is, I think that's what he's planning to do. So very interesting. I haven't come across. I have not
First time I had seen also.
I have done this surgically, but I have not done it radiosurgically, this procedure.
Any other question for Dr. Aditya? All right, I think with that we conclude, and it's been great pleasure to moderate and chair this session, and thanks to all the wonderful speakers and the passion with which the talks were delivered. And I also, it's my duty to also acknowledge the support of Accuray, who were sponsors of this session and has helped in this meeting along with others. Thanks very much.